this video we'll discuss about pyelonephritis. So what is pyelonephritis? Pyelonephritis is inflammation of the tubules, interstitium or renal pelvis. So we have the broad category tubulointerstitial diseases. In that we have ATN and then we have pyelonephritis. So we have discussed already ATN and now we are discussing pyelonephritis. There are two forms of the pyelonephritis, acute and chronic. As the name suggests, acute will have an abrupt onset. However, chronic, uh, it is an ongoing process. But in this ongoing process also, what will happen? There will be acute exacerbations. So chronic will have acute pyelonephritis in between. So in this video we'll discuss about the pathogenesis, the clinical features and the morphology in the pyelonephritis. Now going to the pathogenesis, there are two routes by which the bacteria can reach the kidney. So if this is the kidney, so the one route is the hematogenous. If the person is suffering from septicemia, okay, and the hematogenous route can take place through the blood, the infection can go to the kidney, and this route is less common. The second route is ascending infection. Ascending infection means from the bladder, from the urethra to the bladder and from the bladder to the kidney. So this is the ascending infection and this is more common. So here you can see in this diagram, you can see ascending infection. Now ascending infection are mostly caused by gram-negative bacteria such as E. coli, Proteus, Enterobacter. So what happens is these bacteria, due to any some reason, they colonize in the urethra or the introitus. In case of females, they will colonize over here. And if these bacteria from the urethra, they enter into the bladder, like by catheterization. If there is catheterization of the patient, then the bacteria from the urethra will go into the bladder. Okay, so this is UTI. Okay, this is lower urinary tract infection. Now not all UTI go into your pyelonephritis. Not all UTI, because UTI is very common but pyelonephritis is not that common. Okay, so not all UTI will lead to pyelonephritis, because for the pyelonephritis, the urine, the infected urine needs to grow from the bladder into the ureter and from the ureter into the kidneys. So for that there should be disrupted vesicoureteral reflex, and an intrarenal reflex is also involved. So we will see what is vesicoureteral reflex. So vesicoureteral reflex. Now there is a one-way valve which prevent the retrograde flow of the urine, especially during micturition. So whenever in the bladder the intravesical pressure will increase during micturition, it increases. So what happens is, this is your ureter. So ureter has an intravesical portion also. So this gets compressed and therefore the urine from the bladder does not go back into the ureter. But in case of incompetent vesicoureteral orifice, what will happen is there will be reflux of the bladder urine into the ureters. That means there will be vesicoureteral reflux, and this the reflux can be due to congenital absence of this part of the vesicoureteral reflux, due to absence of that, or it can be acquired also. Okay, so sometimes there is congenital absence, sometimes there is shortening of the intravesical portion of the ureter, so that the ureter is not compressed during the micturition, and sometimes it's acquired like after spinal cord injury, when there is persistent bladder atony. So because of that, what will happen is the urine, now if it is infected, it can enter into the ureter. Now what will happen if it enters into the ureter? Now the main purpose of avoiding the urine is so that no residual urine is present in the urinary tract. But now the urinary tract is again not empty, the urine is again gone into the ureter. So what will happen? There is no there is residual urine present, which will favor the bacterial growth. And therefore vesicoureteral reflux is important in pyelonephritis. Also, when there is vesicoureteral reflex, sometimes there is intrarenal reflex also, so that the urine from the ureters can go up to the renal calyx also. So this is intrarenal reflex that is also involved. Now going to acute pyelonephritis. So there are two type of pyelonephritis as we discussed. There is acute and then there is chronic. In this particular video, we will discuss about acute pyelonephritis. We'll discuss the chronic one in the separate video. So acute, now it is acute suppurative inflammation of the kidney. The suppurative inflammation is mostly caused by bacterial infections. You should remember there is one polyoma virus. Now, polyoma virus is a viral infection, but it especially causes in acute pyelonephritis in immunocompromised person. So, okay. So only immunocompromised persons are infected by polyoma virus. So the pathogenesis, you know. So how does acute pyelonephritis occurs? Either by hematogenous or by ascending infection, which is associated with vesicoureteral reflux. Now, what can be the predisposing factors? Predisposing factors can be urinary tract obstruction, which will lead to stasis of the infected urine. Then catheterization, which will allow the infection from the urethra to go to the bladder. In pregnancy, gender like females, they are more prone because there is shorter urethra. Then vesicoureteral reflux is if there, in diabetes, in immunosuppression. So these are the predisposing factors for acute pyelonephritis. So grossly you can see here the kidneys, they have yellow spots over here. So there is purulent exudate which is present. Now going to the microscopic picture. In microscopic picture, firstly you should remember this. See, these are the tubules. Tubules are present in the kidney, you know. Then there are glomeruli which are present in the kidney, okay. And then there is in between area which is interstitium. So firstly there is interstitial inflammation, okay. Then from the interstitial it will go to the tubule, and from the tubule the glomeruli are the resistant ones, okay. So glomeruli are involved at the last. So starting from interstitium to the tubules and lastly the glomeruli. And what will happen is you will have your interstitial inflammation, you will have your intratubular aggregates of the neutrophils. That means in the tubule, in the lumen of the tubule, you will find neutrophils and neutrophils. These are the intratubular aggregates of neutrophils. And lastly the tubular necrosis, in which the tubule will die. So here in the diagram you can see this is the HE picture. So here you can see this is a tubule which is infected. So in this lumen you can see multiple neutrophils. This is the intratubular aggregates of the neutrophils. Now whenever this condition heals, now when this condition will go into chronic phase or it will heal. Now firstly the neutrophils, they will be replaced by macrophages, plasma cells or lymphocytes. And then if it is healing, it will go into what? It will go into fibrosis. So if you see there will be irregular scarring present over the kidney grossly if you see. And these scarring, if you see microscopically, you will find there is lots of fibrosis, lots of lymphocytes are present because this is a chronic process, okay. And there is tubular atrophy of the involved part. Then now going to the complications. There are three complications mainly, okay. First is the papillary necrosis, okay. We will then there is pyonephrosis, and then there is perinephric abscess. So let's see what is papillary necrosis. So you know there are multiple so firstly papillary necrosis will be seen in certain diseases, such as you have diabetics. This is very important. In diabetics you see papillary necrosis. In sickle cell anemia you see papillary necrosis. So papillary necrosis, what happens is one or the more of pyramids of the kidney. If you see over here in this gross picture, these are the pyramids of the kidney, okay. So pyramids of the kidney, they are involved, okay. Only one single or two single pyramids will be involved. So this is papillary necrosis. And as it is name shows necrosis, so what you will see is coagulative necrosis with, and this response, the necrosis will be demarcated, okay. There will be normal area, then there will be necrosed area. This is the papillary necrosis. Then second complication is pyonephrosis. Now if the condition worsens too much due to complete obstruction of the drainage of the urine, so it can go into pyonephrosis. That means the exudate now fills total kidney, it fills the calyxes, also the ureter with the pus. Okay, this is pyonephrosis. Then third is perinephric abscess. Perinephric abscess means this is kidney and the surrounding tissue is perinephric tissue. Okay, so the surrounding tissue, if the inflammation crosses the renal capsule into the perinephric tissue, it is known as perinephric abscess. So these are the complications. Now going to some lab findings which are seen. So whenever the person complains about dysuria, okay, increased frequency of micturition, you will always go for routine urine examination. Okay, so what will be findings in the routine examination? You can see increase in the pus cells, that means increase in the neutrophils in the urine. Okay, so this pus cells, they can be due to lower urinary tract infection. But if you see something known as WBC casts, so if you see pus cast or WBC cast, so this shows that there has been a renal involvement, because casts, they can be only found in the tubules. So if they can only be found in the tubules and neutrophils are present, that means there is infection going on over there. So if you see pus cast looks like this. It is, you can see parallel lines are there. This is a cast which is found in the tubules, and in that the contents are WBCs. These are the WBC casts. So these are pathognomic of your pyelonephritis. Also you can go for urine culture. These are the lab investigations which we can do for a person complaining of dysuria. Okay, so this was all about acute pyelonephritis. We will discuss about chronic pyelonephritis in a separate video. Thank you.